So let's go ahead and begin, and other people can join as they will. I want to welcome everyone who's joining us today. This is an Aivo-sponsored webinar about living through a pandemic with low back pain. And one of the reasons why we wanted to present this to you is we've been hearing reports of a huge increase in back pain, acute back pain, and increased problems accessing care for people with chronic back pain. So we figured that this is a perfect point in time to share what we know and also listen to some of the experiences of the patients. One of the unique things about Aivo is that it was formed by a scientist, Dr. Apkarian, and a patient, Mika Marjolaxo, I can never say it. And so it's implicitly sort of an anti-authoritarian take on treatment. What I'm going to do is, if we go to the overview of the hour, we will first start with Dr. Apkarian, who will be speaking about the scientist's view. Why is a scientist? Why is a scientist interested in sort of direct interactions with the patient? Then the doctor's view. We have a very unique expert here who I'll be explaining Dr. Hanscom's experience soon. And then I'll sort of round out the end. In between Dr. Apkarian and Dr. Hanscom, we have patient voices. So we'll have questions submitted by you currently and also whenever you registered. So we'll cover those as well. Dr. Apkarian, please start.
Thank you, Dr. Farmer. It's a real pleasure to be part of this event. Let me just switch this slide. And I'm going to spend the next few minutes simply giving you an overview of the science we've been doing in the field of specifically studying patients with chronic pain. My lab has been a pioneer in doing human brain imaging studies in this specific topic. We probably are the first people who actually imaged patients with chronic pain. And the general idea was, is there something we can learn about what is pain if we look inside the brain? The excitement has not ended. This is now 25 years later. We continue to do these studies and we continue to learn about how we understand pain, specifically what is chronic pain, how it comes about, how it evolves in time, what are the brain circuits related to it, and what are the related mechanisms that we can start understanding and using them to properly address the needs and the treatment needs of people who are suffering with pain in general. So this slide highlights three important points that I just want to simply spend a few minutes discussing them. First of all, everybody knows that pain is subjective. Pain, there is no objective measurement for pain. Pain is what the person feels and what the person reports. And one has to respect that and take heed of that. And the primary objective of Aivo would be to get rid of that pain using any and a variety of tools. I should add that that subjectivity, of course, translates into a brain objectivity, which is what we have been doing for many, many years. In a sense, there is a clear-cut, beautiful, anatomical, functional, physiological signature that one can identify in the brain. And so we have lots of confidence that when the subject says that I have pain, there is beautiful physiology behind it. And that physiology gives us the confidence that we can take advantage of those properties to design proper treatment venues. Okay, that's point number one. Now, the other point is that the pain is fluctuating. And I'm going to switch to the next slide and, in fact, illustrate this with a very simple slide. But this is actually, these are data from our published studies from my lab. The first one was probably published probably 15 years ago or so, I don't remember anymore. But it's very simple. These are 5 different people these wiggles on the left are 5 different people rating their pain for a few minutes, literally for about 2 minutes or so. The important point is that no one rates their pain as flat, right? The pain within minutes and seconds goes up and down, and it fluctuates, whether it's high pain or low pain. It's constantly fluctuating. And we have shown, in fact, that there is, in fact, physiological processes that control these fluctuations. So these fluctuations themselves give us an idea of what are the physiological parameters that are changing in time that create these fluctuations. Now, the right panel is a more recent data. These are, I think, 10 or 11 subjects. Each color line is a different subject. And now this is 6 months. These are subjects who are not being treated for anything, are part of a study. They have back pain. And these are over 6 months how their pain is changing in time. Again, you can see that it's a very complicated. So here we have normalized it. So they all start at their initial pain. So that you can follow, for example, the blue line is going down for multiple months, and then all of a sudden it starts going back up, okay? On the other hand, this red one is at this intermediate level and very rapidly goes down essentially to 0, starts going back up again, goes back down, goes up again. And so it has this almost monthly fluctuations of going up and down. The only reason I'm showing you this data is that these results look very complicated, but they have, again, physiological underlying. And when we look at brain properties in these subjects at time 0, when we scan the brain at this time, we can predict these subjects' pain 6 months later. So the brain physiology is in fact showing us, anatomy and physiology showing us the properties and the temporal evolution of pain itself. Okay, let me just, for the sake of time, let me move on to my next slide, and I don't remember what it shows, but this is the slide of a study that we did about 10 years ago. This is a brain imaging study of people who initially have an acute or short duration back pain, and we follow them over multiple years. And so the top timeline is literally showing that an injury happens, the pain goes up, and then this pain is persisting for multiple weeks. And then in some people that persistence stays on, so these people are developing chronic pain, while in others it starts going back down, so these are recovering. So when we look at the brain of such subjects at multiple time points throughout this window, we can start understanding, again, what mechanisms are controlling it, what mechanisms are driving it, and how the pain perception itself is changing. So these brain pictures at the bottom, they look complicated. It's very simple. The green and blue are all the subjects who entered the study initially, and it's their first brain scan. And all it says is that there's a brain activity pattern that's related to the pain that they're feeling, and it's the same for all of these subjects. On the other hand, a year later, when we have another scan 1 year later, the people who are getting better, obviously there's no more brain activity, or it's much less activity, so they're happy, there's no pain representation in a sense. The surprising result is that the ones whose pain persists over multiple years, their brain activity moves away from these sensory representational areas, brain regions where the back is being represented, to brain areas that have to do with emotions, and in a way, and with self-identification. So in a way, the pain that used to be thought as being impinging on them has now become embodied with and emotionally self-centered. So this is exactly the kind of idea that gives us clues as to what would be proper ways of managing such patients and how we can reverse these events. What is not shown here also are all the things that in fact accompany this. This is a physiological reorganization, but this physiology underlies anatomical changes in the brain that are happening in time. And so these reorganizations are what we think of them as rewiring of the brain. What brain area talks to which area, how these synapses are changing with experience. And those are the general concepts that we think we can take advantage of to reverse this signature and relieve chronic pain. And I think my last slide sort of shows all of this idea in a very global way. We think of the sensory input, the back pain information coming into the brain and giving rise to pain perception. And that pain perception itself involves this continuous loop of the interaction of that information with the personality, with the memories, with lifetime events, the properties of the brain involved, and how all of that reorganizes the brain. It either reorganizes it into the relief from that pain, in a sense the pain goes away, or it ends up becoming a condition that's self-referentially, emotionally embedded. So that's the overall general idea. In a sense, this creates for us also characteristics of these subjects, their biotypes, which predict who is more at risk, who will respond more to a treatment, who would respond to what type of treatment better. And those are all knowledge that we can put together into a digital sort of platform that is Aivo overall. So I'm going to stop there as my presentation, and I think I'm just about on time, and go to the next slide.
Yes, and we can return to the next slide.
Oh, okay. No. Let me finish these slides. These points. I forgot that I have one more slide. So, my involvement in creating Aivo really does revolve around very fundamental core values that my interaction with patients and their anatomy, physiology over the last 25 years or so has sort of simplified into, in a sense that yes, there is no question that pain relief is a human right. Everybody deserves proper treatment and everybody needs to be properly addressed as to their need for pain relief. And in that sense, one has to create a large-scale system to address that issue. And current clinical institutions just cannot handle the number of subjects, at least the simple number of subjects that need to be taken care of. And point number two is that the patient is the expert. So we absolutely believe what the patient says, and the whole point is that to interact with the person and to create a narrative that a feedback system within which treatment can be optimized and followed and managed properly. As the symptoms change with treatment, the treatment itself has to change with it, because the brain properties are going to change, brain personality properties are going to change. And so those are all things that have to be dynamically sort of monitored and dynamically adjusted in time. And all of this can only be done in a digital technology platform. And in a sense, I am completely convinced that in many ways, digital technology is the ideal way to manage and treat patients with chronic pain. And in a sense, digital technology provides us an absolutely amazing opportunity to implement these things and scale them at a large scale. And in a way, creating an environment where, in fact, digital technology is good for humanity and not just an economic opportunity taking advantage of people. And in that sense, this technology is also built with the idea that closely monitoring, interacting with the patient, in fact, creates the opportunity of not only empowering society, but creates the opportunity of learning and expanding and optimizing treatment directions. So with that, I'm going to stop, and I'm waiting for Dr. Farmer to come back and
I'm here.
And do something.
Something that just, it came to me as you were discussing this. It seems like the impact of pain can't necessarily be parsed or removed from the pain itself. And just one of the things I think that is a bit mind-boggling is that every single person, you have a different history, different symptoms, different experiences, different impact. How can any treatment system address?
Right, so the treatment systems have to be individualized. There is no question about that. And in a sense, the treatment system has to be dynamic and it's evolving in time, learning from the subject, optimizing for the subject, and from that learning process, generalizing to other subjects as well. That's really what we are trying to create overall.
Okay, got it. One of the questions that we have from patients in relation to Aivo, but also I think this is just a general idea. How long does it take to get better? How long can it take to get better? And
I mean, in a sense, we've already answered the question in that it's going to be unique for each individual, for sure, right? But of course, every chronic pain patient knows that the condition is long-lasting. Our human and animal studies show that reversing chronic pain is hard. It's not easy. And it will take time. And we also know that different personality types or different brain properties will show different types of responses. So in many ways, even shifting personality types from one type to another is another opportunity of, decreasing the duration of treatment in a sense to optimize pain relief.
So listen, can I make a comment here?
David, please, yes.
So first of all, I just want to say I'm a huge body Apkarian fan. I mean, he is a person who's put literally chronic pain on the map as far as the brain imaging. And people get very frustrated in medicine because people can't see the pain. Well, guess what? Dr. Apkarian showed us the pain is there. So it's changed our treatment paradigm dramatically. But I will say, as far as timing to getting better, I've seen people get better as short as 3 days and as long as a couple of years. And it's about retraining the brain. And sometimes you have to retrain new circuits. Otherwise, you can shift onto non-pain circuits. It's like building a virtual desktop inside of another computer. You just literally reprogram your brain. And so the shift can occur very quickly, or it takes a period of time. And Dr. Apkarian is extremely correct in that. It depends on the person, genetics, all sorts of stuff. But I will say this, the hardest part is that it's easy. In other words, it's a process of letting go and moving forward. And so letting go is what's hard. The actual work actually isn't work. It's the opposite.
Right, and in a sense, the hardest part is to have a platform and a medium within which to interact and create the process of working on the subject, I suspect, right? In a trustworthy, protected environment where one can trust, the interaction itself and follow a roadmap in a sense that can optimize it. So I should also say that I'm a very big fan of David Hanscom, and I love his life story, in fact. And this is one reason why I would like to hear him present his viewpoint of how we treat this condition. But what's next, Melissa?
Do we have another question from the patients? We move forward one slide. Let's see.
Oh, I need to move forward the slide. Yes. I'm sorry. Yes.
Yes. And this will, maybe David, if you can indirectly address this, because I want to hear you too.
Yeah,
So let's,
so I mean, this is an interesting question. I like to answer this question because we have generated some recent data on the topic, and it's really fun because, you know, obviously people think that exercise should help, and there's a lot of circumstantial evidence that exercise can help somewhat, to some extent, to some people, for sure. There is no question about that. But what is really interesting is that exercise not only is helping your body posture, your muscles, your bones, etc., which I'm sure it's doing some of that. I suspect. I don't do much exercise myself, so I'm not sure if I know what it does. But on top of that, it also optimizes brain circuitry that have to do with reorganization, with brain circuits that we think are critical for the process of forgetting, the extinction of the pain. These are the circuits that in fact become more hyperactive with exercise. And also the exercise dramatically changes the emotional responses to pain. So those are really exciting recent results that I think are really fun to incorporate in the concept of exercise and pain relief. David.
really quickly, that aligns with one of the older pieces of data I know about the hippocampus, and that exercise is one of the few things that stimulates neurogenesis. Like, we know that that stimulates neuron
Exactly. And now we know that neurogenesis is also critical for chronic pain and for relief from chronic pain in animal models, obviously not in humans. Yeah.
David, please
So,
continue.
Vanya, I guess you have to advance the slides, Vanya.
Oh, okay.
So I'm an orthopedic spine surgeon. I practiced for over 32 years. I quit my practice in December 2018 because I saw hundreds and hundreds of patients going to pain-free. And we were doing spine surgery that had a 20% success rate with horrible outcomes with the failure. And the standard approach fails because the diagnosis is being completely missed. And I want to make a couple points. I only have about 10 minutes here. Is one of them is you saw the imaging that Dr. Apkarian put up, that the brain just stays lit up in chronic pain. It's a brain problem. Now, there's lots of effects on the body as far as neurochemically, but the bottom line is your brain is lit up and it stays lit up. It's like the light switch stays on. And remember, when you feel pain, you don't feel pain in your knee. The knee sends impulses to the brain, and the pain in the brain interprets the impulse as danger. So the bottom line is, in medicine right now, less than 20% of doctors are comfortable treating chronic pain. They look at it as a problem to be managed, not cured. Less than 1% of doctors enjoy it. And the problem is we have the wrong paradigm. This is a neurological brain disease. This is not a bone spur. So I wanted to tell you that chronic pain is consistently curable. I'm now convinced you can rewire your brain around anything. I just have a gentleman who I talked to actually this morning who was in chronic pain for 20 years. He had 27 procedures, including 7 spine surgeries. He was high dose narcotics, alcohol, suicide attempt, and he's been pain-free now for about 4 years. He's fine. Now, I didn't think that was possible. Another woman, 55 years of chronic pain. She's pain-free, she's fine. But again, if you look at the circuits that Dr. Apkarian pointed out, those are permanent circuits. They're embedded. They get connected with more and more life. And the definition that his lab put out there is that chronic pain is an embedded memory that becomes connected with more and more life circumstances, and the memory can't be erased. Medicine came up with a term which I think is really onerous, and that is medically unexplained symptoms. That's not true. Your brain's lit up, your body chemistry is off, your pain thresholds change. The effect of chronic pain has been estimated, actually documented, to be the equivalent of having terminal cancer. It has a terrible impact on people's lives. So your body chemistry is off, your brain's on fire. We have very clear reasons why you have symptoms. Medicine right now has missed it. Next slide, Vanya.
Yes.
So I was in chronic pain myself for 15 solid years. In medicine, we would call it a burnout. And what I have realized that the essence of healing chronic pain is learning to feel safe. And this comes from a psychologist who put together compassion-based therapy. And the blue ring represents your life, things you do, having fun. Red is your survival response, anger and anxiety. And then green is just being contented and safe. So it's sort of a misnomer that life is to be lived in the green. That's not true. And that life in the blue is what life is. But anxiety and anger are survival reactions. It simply is a reaction to input that says danger, with pain being one of those inputs. So you have something that's too hot, too cold, too sharp, too dull, whatever it is. Your brain says danger, creates anxiety, which is an unpleasant sensation. It's a very powerful survival reaction that's necessary to live your life. So the essence of solving chronic pain is learning tools to reroute your nervous system, to calm down your body's reaction to the input. Every day requires anxiety and anger to get through the day, because that's life. I mean, everything has obstacles and challenges. So learning to navigate that red ring is the essence of actually healing. Now, it's a learned skill. And I guess the other thing that upsets me about medicine, and I'll just rant for a second, if you can't see it on a test, it must be, quote, psychological. It is not. It's a programming problem. You saw the slide Dr. Apkarian put up. It is a programming problem. Your brain is on fire. So again, there's many tools to teach your brain to actually reroute and calm down. Next slide, please.
Can I make a comment on that,
Yes.
David? I mean, yeah, and this idea that pain is psychological or not, in fact, everything, all of our perceptions are psychology, right? Psychology
Right.
and the brain are not differentiable from each other. It's just that in some cases, it's harder to show where is the biological evidence for the psychology that we're experiencing. And
Right.
anybody who says it's a psychological result, they don't know what they're talking about. So you should just not even listen to them.
But
Okay.
Melissa, wouldn't you say that 99% of physicians think that way? In other words, if they can't see it on a test, they send them off to the pain psychologist. The cure is actually not a psychologist, it's a family doctor, family practitioner. Because you mentioned earlier, Vanya, that chronic pain is complex. So we're throwing random simplistic solutions at a complex problem. So the only person who can actually solve the problem, by the way, is the patient. Since each person is so individual, they take charge of their own care. And we're the coaches and cheerleaders, but to me, it's a family practice wellness solution. Sleep, stress, medications, whatever. Melissa, would you agree with that concept?
Yeah,
Yeah, go ahead, Melissa. I'm sorry.
yeah, absolutely. And that I think too rarely, whenever patients go in to see practitioners, they feel that they aren't heard. And so they never are able to tell their story and exactly what happens. And if they do tell their story and they tell it in too much detail, then that's interpreted as negative or pathological itself, whenever someone's just really seeking help. So I absolutely agree that each patient is the expert of their pain, and they need to teach us what we can give them, essentially.
So the essence of what I'm trying to say is simply that chronic pain is solvable with 3 steps. One of them is understanding the problem, understanding the nature of chronic pain. The second step is understanding that chronic pain is complicated. There's many variables to it. So everything works in isolation with chronic pain, but nothing works by itself. So the problem is it's always a combined approach, like fighting a forest fire. You have to address every variable at the same time. The sleep, the stress, the medications, all that has to be addressed at the same time. Then the third aspect, which is most important, since chronic pain is complex, there's multiple variables, the only person that can actually solve the problem is the patient. The patient has to take complete control of his or her care. And with that process, we've just had endless success stories, including a number of surgical patients. I have over 120 patients over the last couple of years of my practice that they were on the surgical schedule. They had pinched nerves, spinal stenosis. As we calmed down the nervous system, their pain disappeared. They canceled the surgery. I was operating on less than 5% of the patients I saw in the last 2 years of my practice. So I literally put myself out of business. But I'm now convinced you literally can rewire your brain around almost anything. Next one, I think it's my last slide.
That's your last slide, but you want to give us like 1 or 2 vignettes of actual patient stories? I love your stories about these patients. So let's spend a few more minutes on the topic.
So one of my favorite stories, so my wife and I and stepdaughter put on a workshop back in New York called the Omega Institute. And we did 5-day and 3-day workshops. Turned out they were both effective. But what happened, a girl named Esty came into the first year. She was 32. She had been in chronic neck pain for about 4 years. She had seen 10 physicians, 6 injections, high dose narcotics, and kept spiraling down and down and down. So she came to the workshop and we started this exercise called expressive writing. We started to break things up. We did some relaxation. We worked a lot on forgiveness, which is a big deal. People that are angry have a very fired up nervous system. And by the 4th day, she went to pain-free, completely pain-free after 4 solid years of everything you can imagine. And I just saw her a few weeks ago, and 5 years later, she's now married, 2 children. She's not been in pain for about 5 years, and she's fine. So that's why for me, I actually quit my practice. I have just hundreds of stories just like that. So here she is, 32, spiraling downhill. And not only is she doing well, she's thriving at a level you can't imagine. It is just delightful. So again, treating chronic pain of taking people with no hope, not only giving them back hope, they thrive at a level that they never thrived at before because they're not fighting anxiety and fighting the pain. It's remarkable. Conversely, the reason why I quit my practice, I was making rounds about a year before I quit, and there's a 32-year-old kid, same age as Esty, nice guy. He had a back problem that did not need surgery. Could definitely done well with the rehab that we're talking about today. He had a complex operation, paralyzed. And I just said, that's it. So I saw 3 to 5 patients every week with having surgeries that should not be done, compared to these people doing extraordinarily well with minimal resources and basically self-directed. This doesn't take a major pain clinic. People have Apkarian and Melissa just with your programs and coaching and helping you along can make a huge difference. But chronic pain is an incredibly solvable problem. You just have to get the diagnosis correct.
That's great.
I have a quick question. From the patients that I've been listening to, it's the idea of getting to the point where you can feel safe and trust someone to lead you in a way and create that hope. The hope is very dangerous. It feels very dangerous. The hope can feel dangerous.
Why do you say that?
Just after years of experiences, having hopes dashed by doctor after doctor after doctor, and after a while, it's a protective mechanism. They aren't ready to trust, or they don't. So, you know, one of the things that you're describing to me, you must have created a very safe environment for people to feel like they could open up like that. But how, you know, if someone's like at home and, you know, they're with themselves, how can...
The vast majority of people getting better, the vast majority have done it on their own. They did it on their own. In other words, it's about 90% self-directed. You know, I wrote a book called Back in Control, A Surgeon's Roadmap Out of Chronic Pain. There's a website, backincontrol.com. And by working with primary care, remember the patient takes control. So for instance, with your patients, and the reason why I wrote the book and the website is for any clinician to be able to use the book and website as a resource, then help guide the patients along, but they take control. So by learning first of all, by understanding the problem that they're not crazy is a huge step, huge. And then that starts to calm them down. And then there's this, I think I've told you about this over and over again. There's a book written by Dr. Pennybaker called Opening Up by Writing It Down.
Yes.
There are over 1,000 research papers that document it's a simple step, starts breaking up the circuits. And for me, after 15 years of chronic pain, which was horrible, I started to write by accident. Within 2 weeks, things started to shift. And by 6 months, I was fine. And this isn't the solution, by the way, just a starting point. But you learn tools to actually just calm down your nervous system. So I would estimate with engagement, probably 90 to 95% of people get better. And by the way, repeatedly dashing hopes has been documented in animal studies, in primate studies, to cause depression. The other thing that's so ironic about this is that
it's the standard stress model in animal models. Yes.
Right.
Yeah, absolutely.
So you're right. Most you're dead on is that people go, what the heck? And then there's a different conversation. Maybe Dr. Apkarian pointed out that it took me a long time to figure this out, but people are so used to being in pain, is familiar. It's hard to break out of the pattern. And yet you actually become addicted to your pain. These brain circuits become so deeply embedded. I know I'm dramatically oversimplifying this, but the number one factor that predicts success or failure is willingness to engage. What I didn't understand is that pain is powerful and it's addicting, and people don't want to give it up.
Yeah, whether consciously or not consciously.
Right.
Yeah.
Mostly unconscious, right?
Yeah, yeah. Okay, let me move the slide forward. Okay. This is a
Yes, so these are some of the questions that have been submitted by registration or registrants.
So adjusting the posture, okay, so again, with chronic pain, you take multiple aspects of it and it's never one thing. In other words, adjusting your posture will help. So better sleep, better medications, et cetera. So the answer is it'll help some. It's something that should be addressed. But again, there's always a multiple approach to solving chronic pain. So the first question is this acute pain less than 3 months or chronic pain? And if it's acute, posture makes a huge difference. If it's chronic, it helps some, but I would still recommend doing it.
Okay, shall I move on to the next slide?
Yeah. So that's where I mentioned earlier, I'm convinced now, I had, again, over 120 patients with surgical problems, spinal stenosis, that just flat out canceled the surgery because literally they programmed their brain around the pain circuits that were there. Degenerative disc disease, by the way, is simply not a cause of pain. We don't know where back pain comes from. We know very clearly that there's no connection between disc degeneration and pain. It should just be called a normally aging disc. And again, there's something like $20 billion of surgery done on a year in the United States alone on degenerative disc disease. The success rate of a back fusion for back pain for degenerative disc disease is about 22%. So that is simply never a reason to do surgery.
And in fact, that number is, I think, 100 times smaller in Europe. So
right, no, we're out of control here in the United States.
Yeah.
Next.
Okay.
Something that I guess I want to mention really quickly is that in animal studies and human studies, it is quite clear that the factors that initiate the onset of pain that becomes chronic are not the same as the ones that maintain it over the long term. And this is a distinction that a lot of clinicians don't make. They always sort of search for that initial, what was the initial infection? What was the initial injury? And what we've seen in the scientific studies again and again is that triggers a cascade of events all the way up to the brain that, you no longer need that initial injury to maintain that response.
Right.
Yeah. So
Absolutely.
Targeting the injury is the wrong target, right? Yes. Yeah. Okay. All right. Let me move on.
Well, again, this is a very complicated answer. So I would just recommend, again, whether this Melissa's approach is structured and documented, my approach, which again, whatever approach addresses all the variables, it doesn't matter exactly how it's administered, but the factors that affect pain are sleep. There is the anxiety, anger part of it. There's physical conditioning, medication management. And one of the most important ones is, by the way, is life outlook. Just how you view life in general. If you're negative and pessimistic and angry, why your brain develops that direction. One of the most powerful treatments that we started a few years ago is if you were in my office, Melissa, I say, look, when you walk out of the door of my office, you will never discuss your pain ever again the rest of your life. And I didn't realize that people in chronic pain, including myself, talk about their pain all the time. Well, that's where the brain's going to develop. If you look at it from terms of neuroplasticity, is that one of the most powerful things we found right behind expressive writing has been simply never discussing your pain, period. And people don't know what to talk about. But a huge, huge shift occurs within weeks, just that one intervention. It's amazing.
Okay, let me move to the next slide. That's great. Okay.
Before we jump to the lessons learned, do either of you want to say anything else? This is sort of a regurgitation of what we've discussed so far, but
well, why don't you cover these and then maybe we can have a discussion afterwards. Okay. Yeah.
Okay. So some of the points we covered here, and also just our personal feelings about this, is that we've seen again and again that the existing healthcare system doesn't have the capacity. It isn't built in a way that can address individual pain. We don't have enough knowledge, first of all, to be able to select one specific treatment for one specific person. And so it ends up being a sort of mix and match situation in most healthcare practitioners' offices. the other thing is that this, and I think it was David that made this point, the healthcare system itself, just going to the doctors, it becomes a conditioned fear experience. It makes it worse. And that is exactly what doesn't create a feeling of safety. And I think that one of the things that we're trying to do with Aivo is use some of the knowledge that exists now that otherwise wouldn't get to patients for 10 plus years and share it directly with patients, in that the time that it would take for us to educate doctors, for doctors to sort of marinate on it and come up with guidelines and then actually practice it, someone would be living part of, like a large portion of their life in pain. So one of the reasons we have this is we want to get this information to people now. So a lot of the research from Dr. Apkarian's lab, even though it came from this sort of basic science perspective, is ending up being much more clinically relevant than perhaps he expected. He always makes fun of psychologists. He's becoming one himself. One of the things that we've been trying to grapple with is how to create an active engagement through something like an app. So how can you engage in the information? How can you engage in the knowledge? And how can we help create experiences, novel learning experiences that help you rewire your brain in a way that matches the level of activity, of social interactions that you want, of feeling as if you're yourself, you're no longer part of your pain. And so this is one of the things that we've really sought to do. Any other thoughts?
Is this the last slide?
No, but I'll talk a little bit about the app, but it's,
okay.
Yeah, some free time.
All right.
Well, I will say, I'm gonna hold I'll just rant for a second. I'm holding the business of medicine largely responsible for this pandemic. People we're geared towards illness, not wellness. Our hospital administrators actually push us to perform procedures that have been documented to be ineffective because they're profitable. And as far as the knowledge, we have the knowledge. It's just that they're not covered by insurance. There's many, many documented treatments for chronic pain with mindfulness meditation, the biofeedback, there's many, many things that are effective, but the healthcare system is not paying for them. So they're very focused on profit. And one of the biggest ones is that they refuse to pay doctors to spend time with their patients. So remember, safety versus threat. When you're under threat, your whole pain system is heightened. When you feel safe, your system's calmed down. So we don't have time to feel safe with your doctor. And if you can't feel safe with your doctor in this world, where do you feel safe at? So two things: you don't feel safe with your doctor, plus the doctor doesn't have time to actually figure out the problem. So there's just endless amount of suffering with patients. Most people that come to me, probably 80% of the people that come to me with chronic pain, have had these bone spurs for years. The pain started 6 months ago. And I just hear tremendous stories of suffering that kicked up the pain. Suicides, financial losses, job losses, horrible things coming up, horrible things. And doctors never answer the question. In fact, one of my favorite patients, 55 years of chronic pain, she's now been pain-free for 6 years. But the doctors didn't ask her when she's in her 40s that her husband committed suicide. And then 5 years later, her son committed suicide. Nobody ever asked that question. So it's about safety versus threat. Doctors don't take the time to find out what's going on, and they don't have time to feel safe with their patients. Every provider I know that's effectively treats chronic pain is the doctor-patient relationship is number one. And the things that we're talking about here are the techniques we can add on top of it. So we have the knowledge, but the resources are being badly misapplied.
Yeah, I mean, I guess I should just add a few points in a sense. I guess what is really important also is to remember that it is not a mysterious condition. It is understandable. There's clear physiology behind it. There's clear anatomy. There are multiple pathways. Both human and animal studies are complementary to each other. And the combination of those are giving us amazing, beautiful knowledge. And we can take advantage of that knowledge. And, you know, a lot of the treatments out there that David is talking about are trial and error treatments. Can we further objectivize those treatments based on the specific history, you know, personality of the given patient? I think we can, but that's a roadway we have to travel. And in a way, Aivo is really designed to create that pathway forward. The other important point here is that, I mean, I love, David, your stories because, in fact, they create hope, right? And by and large, the medical literature says chronic pain, we can manage it, but we cannot treat it, which is really the wrong message to start with.
It's wrong. Yep, yeah, it's wrong. Yeah.
Yeah. So, and in a way, Aivo is being designed to really scale up and really create a safe environment where one could rewire the system based on the specific properties in an optimizable way that, in fact, can deliver it across the planet, actually, in the long term.
Well, again, Ivani, I want to honor your work because here's the deal. There's not one research paper that documents, not one in 50 years, that documents that spine surgery works for back pain. Not one. Your research and other neuroscientists around the world have documented in hundreds, probably thousands of research papers now, the nature of chronic pain. And you're absolutely right. It is not a mystery. So it's a mystery is why this knowledge hasn't penetrated into mainstream medicine, because once you understand the problem, it's just not that hard to solve. We have the wrong diagnosis. We have the wrong approach. And Melissa, I also want to second your point is that I've given up on physicians. I had my colleagues watch me treat dozens, hundreds of patients and watch them go to pain-free. And people go, well, that's great. I think one person asked me in 20 years, well, what are you doing? What's making this so effective? Nobody asked. So doctors get entrenched in their pathways. They're not bad people, but we're so busy, so overwhelmed. We just do what we know to do now.
The system that they're embedded in just does not have the time, the opportunity, the intellectual space to really seriously tackle the problem. Yeah.
Right.
It's an average of 4 to 11 hours of pain education in, I believe, 97% of medical schools in the US. And that is including, in the US, 97% of the schools have pain-related content. Of those schools, 4 to 11 hours of direct instruction on pain is provided to medical students. So whenever you see any doctor, on the high end, if they were lucky, they've received 11 hours of training, thinking seriously about normal pain, not chronic pain. And so it's mostly normal pain and then post-surgical opioid use. So
right, and that's a good point, Melissa, that I probably did not make clear, that I should make it clear again. Acute pain and chronic pain are not the same.
Correct.
They are completely different. And this is why that slide that I showed you, the brain activity for acute pain shifts to a completely different universe in your brain when it becomes chronic. And when we saw this, we were, baffled. And a lot of people would not, believe the results initially when we first published these papers. And now they've been replicated both in human studies, in animal studies. The same process happens even in the rat and in the mouse. So it is not a mystery. It is a physiological process. And it's reversible and it's identifiable. Yeah.
I mean, psychology might add 10% to the treatment, maybe 15%, but this is not a psychological problem. I mean, it helps, right? But yeah, no, it's definitely, and then going straight to the patients, what I was trying to say earlier, going straight to the patients is absolutely critical right now.
Yeah. Right.
I wanted to ask if any of the viewers, if you want to ask a question. I know that there are some people who are physical therapist, for example. If you have any questions, just type them in the chat and we can answer those.
Should I change the slide, Melissa?
Sure. Oh, ding dong.
That's my phone, but I'm just trying to go, but I'm not going to answer it.
So I'm going to go through this really quickly, just in that in the questions question and answer section, not the chat, if you have any questions. What Aivo is, we aren't providing a treatment. We are sort of agnostic whenever it comes to treatments, in that whatever treatment works for an individual patient, that's what we're behind. The problem is trying to figure out, for a certain patient's symptoms and their pain history, what is the right combination? What is the recipe for their treatment? And that's essentially what this product is. It's listening to the patient, studying them in as much detail as possible, day to day. If your pain goes up in the morning, someone's asking you in the afternoon what happened. And that we're trying to use sort of the magic of digital technology and artificial intelligence to be the treatment provider that every patient wished they had. Someone who would listen to them, who knows exactly whenever things start to get really tough, and is there to ask, hey, what do you need? And so this is just a few screenshots of the app that we've created thus far. We're beginning a clinical trial. If anyone's interested, we have some information on the last slide. But one of the things that this product is aimed to do is to bridge the gap between the patient and the science, bring them directly together to where the patient can have the science work for them on a day-to-day basis. And I think that's
Okay.
essentially what I want to say.
Okay.
One of the, if you advance the slide, one of the questions that we've received from a provider is, how do I engage patients online? And this is something, especially during the pandemic, a lot of the conversations I've heard of among physical therapists for sure has been, how do I continue to treat people who are relying on me whenever they can't come in? And it is challenging. Some of you sort of know part of it in that it's the therapeutic alliance, creating the trust, the engagement. So that hasn't changed. But one of the ideas is, we think one of the main opportunities here is to create a conversation and a method to engage with the patient in their daily life. In that it isn't just, you aren't restricted just to a single session. You're able to interact with patients as they're going through their daily challenges. And so we think that this is one of the strengths of doing digital work.
Can I say something, Melissa?
Mm-hmm.
So here's the key. Two things. One of them is that this is not about some belief system that you have to believe, you or Vanya or myself, that I'm going to believe and I'm going to be healed. So this is about connected and engaged thinking. So I tell patients, look, you don't believe what I'm saying, fine. That's really important to understand that you don't believe me. That's fine. So it's about neuroscience and change in the brain. So if you don't know what's there, you can't change it. So the word I would use is suspension of disbelief. And then, because honestly, you decide you want to get better or not, that's fine. If you don't want to get better, that's fine. Be honest with yourself, but simply start doing the work. And so then the second thing, as far as the online resources, when I give lectures to physical therapists and physicians, I say, look, the number one factor that predicts a good outcome or not is simply patients' willingness to engage. So my answer to the clinicians that are listening is, if a patient really is just angry and frustrated and not open to change, you got to let go, because the more you try to push them, the harder it gets. So it turned out to be I need to research. I learned I had to save my energy for patients who wanted to engage. I could help them along, and they would consistently get better. But you don't need personality tests or whatever. You just got to figure out whether someone's willing to engage or not. So as you unload the responsibility onto the patient, or they take it, the whole process becomes delightful.
Hmm. And I think that, you know, if you look at the motivational interviewing procedures, people are at many different stages in the process of wanting to get better, being hopeful that they can get better, having faith that they have the capacity to, and there are opportunities to encourage someone from one stage to the other, but ultimately it is a point where you feel like you're ready and that you want to take the leap.
Right, so that's where an app just comes as a great resource for that journey. It's not going to substitute for the patient taking charge.
No, no, no. It's in fact making sure that the patient takes charge and
Right.
simply becoming a venue through which the patient learns how to take charge of their situation. And it just becomes, you know, a continuous feedback that they can monitor themselves. They get enough information about where they are, where they have been, and have that in a cumulative process that in fact you can see the road that you're traveling as well. That's in
Right.
fact definitely part of this, and the success of the road for us, I think, is also a very precious event in that it gives us new information that we can empower new patients as well. So that's kind of the symbiosis of the system. That's how it's, at least I envision it working when it's up and successful in a way.
So I want to, we're at 3 p.m. Let's go ahead and close up. I want to thank the guests, Dr. Apkarian, Dr. Hanscom, and if anyone has any questions, any follow-up comments, at the last slide we'll have some information. Vanya, can you forward that?
Okay.
You can email me directly and I am happy to engage with you. So thank you so much for checking in, and for future viewers, still, please contact me and let me know what you think.